Hi everyone, and thanks for joining us today. Your lines are muted, however we invite your questions and ask that you submit them at any time during the presentation by using the Q&A function. The National Association for Healthcare Quality is an association that supports the healthcare quality profession. We define the standard of excellence for the profession and identify and validate the body of knowledge required of healthcare quality professionals and provide them with the tools they need to meet that standard of excellence. We also offer the only accredited certification in healthcare quality, the CPHQ. With over 10,000 CPHQs worldwide, these professionals are universally recognized as qualified in their work and advance the profession of healthcare quality. We also provide extensive educational programming for those new to the field to seasoned pros. HQ Principles, an online certificate program, establishes a great foundation for those just starting out in healthcare quality. For those planning to sit for the CPHQ exam, our CPHQ prep resources could be just what you need to feel as prepared as possible. With an online learning course, in-person workshops, books, and practice tests, you're sure to find a study tool that fits best for you. And for advanced and master practitioners, we offer HQ Essentials, the essential competencies for the healthcare quality professional. HQ Essentials define the expanding and emerging healthcare quality professional roles of today and tomorrow. These programs and resources, along with our peer-to-peer networking and member engagement platforms, provide healthcare quality professionals with the end-to-end support they need to be successful in a fast-changing healthcare environment. Beyond membership, we collaborate with institutions, corporations, and other organizations to advance the field of healthcare quality to offer leading-edge and relevant content to our members. This brings us to today's complimentary webinar with Nuance. Nuance is a leading provider of voice and language solutions for businesses and consumers around the world. Its technologies, applications, and services make the user experience more compelling by transforming the way people interact with their devices and systems. Every day, millions of users and thousands of businesses experience Nuance's proven applications. Our topic today is what quality professionals need to know about CMS's Physician Quality Payment Program. And our speaker today is Catherine Gorman-Klug. Kathy has over 30 years of experience in healthcare. She has extensive experience in project design, implementation, and management. In her current role as product manager, she is responsible for product strategy and product marketing for Nuance's quality products. Previously, as corporate director of privacy and data security, she was responsible for compliance with requirements imposed by HIPAA and other regulatory and accreditation standards for an integrated health system with over 7,000 employees. Please join me in giving a warm welcome to Kathy. Kathy, I'm going to turn it over to you.
Thanks very much, Jackie. Hi, everybody, and welcome to today's program, which, for those of us who have been following it, really does seem to be ever-changing. Even when we have a final rule, then there's a proposed rule to change the final rule. So today we're going to address what we know, what we don't know, and what may change. Albert Einstein basically, as he said, if you can't explain it simply, you don't understand it well enough. Well, I'm hoping I'm able to explain this simply today because I have been reading this rule since the very beginning and all its various changes, and it's something we follow very, very closely. We're going to go through what is MACRA and the quality and finance professionals' greatest areas of concern and misunderstanding. Because, as we know, with all things CMS related, there are financial penalties and opportunities. Who can and cannot participate? What has changed? The latest changes in the proposed rule, and quality reporting and CDI considerations related to MACRA. So the impact, as most things, when the rules change, are far-reaching. They impact not just physicians, not just physician practices. We all know that most facilities at this point, not just the large IDNs anymore, actually employ physicians, whether they are in faculty practices or individual practices or hospitalists, as well as a myriad of other professionals that are impacted by this. And what we also have learned through the years, as rules come and go, is that in general, even if you are on the hospital side, the expertise of the quality professional and the financial professionals on the hospital side are very often looked to be the subject matter experts to help to implement this and to figure out ways to improve everyone's outcomes, especially when there's money on the table. So earlier this year, in advance of HFMA A&I, we actually did a hospital executive study about the quality payment program. We wanted to see really if the temperature that we have on the environment really is supported. And as you can see, we guessed that there is a significant lack of knowledge about the implications. What's very interesting is that they say that while they were confident that they understand the requirements, when they look at what really is required, they feel that their confidence is not really where it needs to be, especially when it comes to the financial impact. This is consistent. Ours was one of the first studies that was done, but if you are like us and you follow this, there's subsequently been other studies by some of the large consulting houses that have had the same outcome. So we know now that there is a knowledge deficit. This is not a new program. This program was introduced almost a year ago in August with a final rule that came out last October. But this year, the rubber is really hitting the road with the impacts. So, the concern is that organizations are going to be left not prepared or ill-prepared, and they are going to be leaving money on the table. And as you'll see as we go through, the margins are pretty high of what the risks are. So these are the top things that they are least prepared. I'm not going to read this to you, but obviously capturing clinical documentation and developing business processes to ensure that everything is documented appropriately. These are not the same as what most of us are used to in the traditional quality world. This kind of makes the transition from chart abstracted requirements to ECQMs look like a walk in the park, because in most cases we were dealing with, whether we're on the vendor side or on the hospital side, with folks very experienced in the world of quality. This is very, very new to physicians, and in most cases, it's not as we know, the physicians themselves will not be performing the required reporting. It will be someone on their staff, and that's where really the turn to dedicated quality professionals, whether they're somebody who is now dedicated to doing things on the physician side or just adding another cap in the caps that most of us wear. Again, this was okay, there we go. What was interesting is, as we said, we did, this was a C-suite level survey, and respondents feel, especially in finance, that they really need better awareness and education for QPP. A few mentioned that there's going to be a very difficult period of adjustment. This is nothing that we all haven't heard before. And some of them say that they see the benefit in moving forward. While this is called the QPP, in my mind, and I think in almost every quality professional's mind, this really is value-based purchasing. But just for physician practices, it's not the same as the hospital side. But I recall when value-based purchasing first came out, getting calls and questions from, CFOs or other folks in the rev cycle saying, can you explain, I need to understand how quality impacts our bottom line. There really was a huge deficit in knowledge at that point because, let's face it, most of the financial folks at that point really didn't pay much attention to core measures, ORX, or any of that. It was the folks who handled, the accreditation surveys and when CMS came on to make sure there were no citations. So we're really coming full circle now, and this is really, very, very far-reaching. The quality respondents say QPP are a burden. This impacts especially the smaller hospitals. Some of the smaller hospitals, have one person who's doing physician credentialing, risk, quality, patient safety, and probably whatever else they can give them, maybe the staffing office. A few of the quality folks say that they've been prepared because they've been tracking this all along. Some say that the EHR is going to be helpful, but uncertain how much help an EHR is going to be. And I think that also speaks to what we've seen now that we've gone through a full year of ECQM reporting, where many folks, especially on one of the webinars that I've done for NAHQ in the past, that those were the comments that we had gotten, that the EHR was not as helpful as folks were hoping it was going to be for the ECQM requirements. And knowing that there are a lot of physician-based EHRs out there, some very small, some homegrown, that they are using still, this is definitely going to be a challenge for these practices and the organizations that support them. This was just a quote from then acting CMS Administrator Andy Slavitt. So really hoping to free up physicians to do what they do best and need to do best, which is to take care of physicians and patients and be available to deliver high quality, low cost care. Physicians, when you speak to them, do not see this rule as promoting that. They just see this as another burdensome, reporting requirement, which obviously is human nature. So MACRA, which is the Medicare Access and CHIP Reauthorization Act, because it wouldn't be a rule if there wasn't an acronym for it, repeals the Medicare Sustainable Growth for Physician Payment. Now, we know the SGR methodology was also very controversial. Folks did not like that either. So the effort was to make this a kinder, gentler rule so that more folks could participate with less effort. So they established the new methodology, which is the QPP, and there was a final rule. However, as you see below, the proposed rule was released on June 20th of this year, 2017, with significant changes. The comment, and I mean significant, the comment period either closed on the 20th of this month or is closing in the next day or so. When I last looked at the comments, there were not as many comments as I would have expected. However, there were many, many comments related to support for education for physicians, assistants, and other allied health professionals. They had a template that they sent in. There was probably thousands of those. The physicians that I did see, let's just put it this way, none of them were in favor of the rule or the changes to it. So with all things, whether it be Joint Commission, DNV, CMS, new rules, new requirements come with their whole list of acronyms. This is really our word jumble right here. These are new things that have come out. Some of them, are traditional, such as measure. We talk about MIPS, we talk about registries. What is a group? Advancing care, redundancies. What all of this, what does it mean? What is pick your pace? So these are definitely the terms that you will see. So what they really wanted to do was introduce more flexible reporting in year one, because in the prior rule, folks felt that it was very difficult to get all of this data together within the first year. And we're seeing that, on the hospital side now with the relaxation for ECQMs, with neither CMS nor Joint Commission requiring a full year of ECQM data. So we're seeing, the alignment that we want to make things more flexible. There was criticisms in the old rule that there were that smaller practices could not reap the benefits, the financial benefits, because they did not have the volumes. That's changed. They also established something called advanced alternative payment models. This is a subset which is a little bit riskier than the MIPS, and we'll go into that as we go through. And there are certain requirements that you have to fulfill to actually be able to submit the APM model. They simplify the all or nothing EHR requirement, which is a good thing. because, as I said, there are still some physician practices out there, a good number, in fact, that are either using EHRs that are not supporting physician quality or are homegrown and never will. So they added alternatives. Establishes the medical home to improve care coordination. Not going to speak too much about that, but just on the side note, when you look at the medical home model, that is the most advanced in the Medicaid population, and particularly the pediatric Medicaid population, and not so much within the Medicare. The literature does support that, and there have been a lot of comments and a lot of disdain from the folks who have established very good medical home programs that they are not able to participate in the financial benefits laid forth for the Medicare patients. So they created two models, the APM, merit-based, which is otherwise known as MIPS. CMS is saying that this is 600,000 eligible providers. The 60-day comment period on the proposed rule is either in flight or closed yesterday or today. So as you can see, that's a very, very large number of providers, and that's probably going to climb as you look at the proposed changes. Okay, it's very interesting when you look at this statistic as how many Medicare patients there are out there. It's more than 55 million of the country's seniors and individuals with disabilities. So it's not just seniors. Who qualifies? Providers such as physician's assistants, hospitalists, nurse practitioners, CRNA, clinical nurse specialists. And keep in mind, please, that this is under the current rule as it stands. This is not the proposed changes that were released in June. My advice to folks, and what most folks in the industry are doing and saying, is that as you prepare as if this is going to remain the final rule and the final reporting requirement. So this is for folks who bill more than Medicare, $30,000 annually, or provide care for at least 100 Medicare patients annually. So that's an either or. Deciding which program to pick, this is not an option, at least under the current rule. They only, depending on how you practice and how you are set up, that drives which program, whether you report under MIPS or you report under APM. Okay, what are these alternative advanced payment models? So these are payment models for those basically in an ACO, and they are providing added incentives, and obviously with added incentives comes added risk, to deliver high quality and cost-efficient care. These can apply to a specific condition, which is determined by CMS. This is not, you're not able to pick a specific condition that you feel you're doing well in, if you will. A care episode, an entire population of patients across the continuum, and it's designed for practitioners in specific VBC models, such as ACOs. So CMS is estimating of that 600,000 clinicians that are eligible, roughly less than a maximum of 20% of them will be eligible to participate in this model. So as I said, this is not the model that we feel that most practitioners are going to go with. This is what they have defined for 2017: comprehensive end-stage renal disease, comprehensive primary care, Medicare shared savings program tracks 2 and 3, and a next-generation ACO model. They had promised to add additional ones, but with some of the changes in the proposed rule, that does not seem to be the case. So providers who receive 25% of their payments through Medicare or see 20% of their patients through an advanced APM in 2017 will earn a 5% incentive payment. Now, keep in mind, just as we know in the value-based purchasing model, that's a 5% incentive or a 5% at risk. So merit-based, this is the one where we see the lion's share of practitioners participating. This, as it's called, is the MIPS program. That's the acronym for that. It's obviously a program for certain Medicare enrolled practitioners. This is the traditional fee-for-service Medicare that's been around for many years. It consolidates 3 programs into one. It's PQRS, although I will be quite honest, when you look at the measures, although there's more of them for PQR than there were for PQRS, they're very PQRS-ish, if you will. The physician value-based payment modifier, as well as the Medicare EHR incentive for eligible physicians, so professionals. So, CMS is saying that they're thinking 500,000 clinicians will participate in MIPS in its first year. Unlike the world of PQRS, where we know that many practitioners decided that the hit that they were going to take was not significant enough to force them or to engage them in reporting that they felt that it was financially really a flush, if you will, to participate or not. That is not the case with MIPS. They realized that was probably not the best incentive of letting the practitioners decide, and was not going to help them achieve their goal. So obviously this encompasses quality, cost, use of certified electronic technology, and avoidance of redundancies. So when you look at this, quality of care is 60%. It's the biggest piece of this. So reporting on the quality measures and doing well on the quality measures is the biggest piece of this. Advancing care information is something I personally think that, and what I've heard from practitioners, is something that some of them may struggle with. And I think when we go into what the requirements are, I think you'll see why we feel that way. And improvement activities. So the adjustment will be up, down, or neutral or positive, up to 4% in the first year, as opposed to 5% in the first year for the APM model. These incentives, or penalties, if you will, are growing pretty aggressively. They'll be up to 9% by 2022. Those who are familiar with the inpatient model know that this is a much more aggressive increase in penalties and incentives than we've seen on the inpatient side. So hospital-based physicians, these are the folks that are outpatient clinic or an ED who really felt left out in the past. So now they are able to participate as long as they provide 75% more of their care in that setting. This does not apply to, a field-based physician who's on call and comes in to take care of an ED patient. This is designed. There's different requirements for them. Non-patient facing, such as radiologists, telehealth, they are now eligible to participate. They weren't, but again, they have made changes to really be all-inclusive to meet the goals. So pick your pace. What is that? Pick your pace is a new term. Several options. If they were prepared, they could begin collecting data on January 1st of this year. They also could begin collecting data anytime between January 1st and October 2nd. But whichever you chose, the data for either option was due to CMS no later than 2018. And whatever you're collecting in 2017 impacts the payment for 2019, the same, traditional CMS model. What are the reporting options for MIPS? You have to report on up to 6 quality measures, including at least 1 outcome measure for a minimum of 90 days within the attestation window. If you're a group, which means you're reporting under your group NPI number, and And when you report as a group, everybody shares the wealth or everybody takes the risk of the penalties. And you have to attest, not demonstrate, but attest. But from what we've seen in some of the audits that are going on with the traditional MU world of attestations, I really recommend folks that they don't attest to anything that they really don't have in place. Quality improvement activities for a minimum of 90 days. Complete the security risk analysis, and attest to the ability to do the following: e-prescribing, which is probably the easiest in many states to attest to, because many states now require e-prescribing. This is where I think there's going to be some struggle. Providing patient access to data, sending summaries of care, and the ability to request and accept summaries of care. The goal of that is electronic. While we know that on the hospital side and some very, very large practices, especially those owned by hospitals or IDNs, do have patient portals associated just for the practice, that is definitely not the norm. And I know it's not the norm, especially here where I am on the East Coast, unfortunately. And in speaking to practitioners, this is something that they really struggle with, which is not a surprise. So you can also report as an individual or a group using your NPI number. And there are options to report, such as a certified EHR, a qualified clinical data registry, which is either a registry from an approved professional organization or any of the myriad of registries that are out there, those that are supported by traditional quality measures vendors as alternatives, or through routine Medicare claims processing, which I think is the one that has most folks nervous about. It's really, it's a little bit better than the CART reporting, but you really don't get the reports that you would get if you went through your EHR or a registry. This is how a group is defined if they have, by their NPIs, no matter what the specialty or practice site is. So if it's a large, practice that has everything, they can report together as a group. They will get one payment adjustment, up or down, based on the group's overall performance. Again, these are the options. They submit, this is a different option that they have. This is different through the CMS web interface. That is not the same as what we discussed with traditional Medicare claims data. This is a dedicated web interface that was set up just for groups. The registration period has passed. And again, they have the same options, such as a third-party data, such as a certified EHR, a registry, or a qualified clinical data registry, such as the American College of Radiology, as an example. So selecting measures to report, this is key. You want to look at the clinical conditions that you usually treat, not the ones that don't make up the bulk of your practice. Look at the type of care, whether you're preventative, chronic, or acute. You really need to know your patient population within the practice. Know where you deliver most of your practice. And look at what your quality improvement goals for 2016 were. This is really where your clinical documentation improvement staff and your coding staff really can be of assistance, because they will know probably very quickly what the breakdown is of the type of patients that are normally treated within the practice. And other quality reporting programs that you currently have in use or are being considered, such as the ACR and the ACS reporting. There's 271 measures available, which is significant. It's a large number. So it really is, there's something for everybody out there. You need to review and select measures that best fit your practice as stated. CMS has done a wonderful job on their website with this. They have great tools out there that really it's very intuitive. They really did a phenomenal job. I mean, I can say nothing less than how well they did this. Allows you to select your EHR, select your type of practice, what type of patients you normally see, and additional care categories, and you can run an algorithm which is exportable to a CSV file as well as an Excel spreadsheet, so you really are able to determine what is best for you. When you need to select the 6 measures, you have to include one outcome, and say this is right from their website. You can use the search and filters to help you find it. And as I said, it's very, very intuitive. Okay. So advancing care. This is replacing traditional meaningful use. What is required here is a security risk analysis. This is something that what we're saying is unless practices are part, again, of a large IDN or a very large practice, is something where they're looking to the organizations where they are credentialed to help them with. The best we can probably, the best analogy I can come up with was when we were all preparing for the privacy and data security rules, in the early 2000s, physicians' practices really looked to the larger organizations to help them to create the forms, to create the data fields that they need, and to kind of walk them through and do the education on that. I see this in the field as being very, very similar. E-prescribing, as I said, that's probably one of the easier ones, especially if folks are in a state where this is mandated. Providing patient access. These requirements are the same as they are on the inpatient side, and it's access in whatever medium the patient asks, including electronic. They need to be able to send a summary of care to the patient, not upon patient request, but when there's an episode of care, a summary must be sent automatically to the patient. And if they know that their patient has been seen somewhere else, whether it be a specialist or a local ED, or even if someone's on vacation in another state, to be able to send a request to that practitioner for a summary of care and to be able to receive it electronically. And they do put in some optional measures to increase your score. So advancing care, there are 2 measure sets for reporting. The option you use is based upon your EHR edition. So there are 15 measures depending on option 1, which is a certain subset of EHRs, and under option 2, there's 11 measures available. So you do have the choice to which one you're going to pick based on your EHR, and they really did a nice job of aligning what the measures are with what the knowledge they have or the knowledge they were provided as a for the EHR capabilities. So the improvement activities. Most participants will attest that you completed up to 4 improvement activities for a minimum of 90 days. It's not so many. If you have less than 15 participants, you only have to do 2. If you are certified patient-centered medical home, which we're not seeing very many out there, they automatically earn full credit. Participants in certain APMs, such as shared savings, will automatically be scored based on the requirements in the APM. So while there's less work, as we've said in the APM model, there is certainly additional risk. Transition year, this is what they're calling this, the 2017, where you can add on additional bonuses, if you will. If you are using a certified EHR technology, if it's your standard practice to report to public health agencies as required in many states, report to clinical data registries, which, again, those are usually the professional organizations that have them. And a 5% bonus credit will be awarded to providers who do both. So 5% on top of the 4% is actually a very nice bonus, and in some ways could actually mitigate some of the other revenue at risk. Small practices, yes, they're exempt, but they are eligible, and that represents like roughly 33% of clinicians, accounting for only 5% of Medicare spending. However, in order to really make this all-inclusive as they really feel that it should be, they are offering options to basically create a virtual group within certain geographic area or within certain areas of practice to create a group that is large enough that you can report. And you can report but as a group. So you have to join together. So again, there is the risk there of not reporting as a solo practitioner, and unless you know the outcomes of the groups with whom you're aligning, really could give you some risk. CMS really likes this option, and they really want to encourage more folks to participate. So they have set aside over the first 5 years of the rule $100 million for training and educations for practices with 15 or fewer folks or those who work in underserved areas. Coding considerations. You know, the old saying, if it's not coded, you know, if it's not documented, it can't be coded. If it can't be coded, it can't be mitigated against. So coding is obviously very, very important to this. When you look at the measures that are out there, there is a significant focus on ICD-10 specificity, significant. If you are going under the APM model, there's a large focus on HCCs. Physician documentation will really need to be examined and increased with the need for increased specification and clarity, even above what was required for ICD-10. You know, for the coding professionals, they'll have the ability to take a lead in educating the physicians and the staff and working with them to show them what the codes are required to show compliance with the specific measures, just as has always been the case with the inpatient measures. So here are the proposed changes. Again, as I said, these came out June 20th. The comment period is either closing or has closed. And what they've really done is they raised the volume threshold for reporting. So it's really impacting less folks. They are adding bonus points for the scoring methodology. So they're making it a lot more lenient and easier for folks to manage. Recalculate the weights of the components for the composite score, which is something that we see frequently. In an APM, it establishes a threshold for revenue at risk for both parts A and B. That may be at risk to qualify till 2020. Provides detail on all payer options for 2019 reporting, which obviously is all payer is significantly different than just Medicare. Medical home, the risk is going to rise more slowly, but statistically what we're seeing out there is that there are not as many medical homes as there are folks that are going to fall under the MIPS and the MACRA piece. And they introduced a new program, and this is not related just to the medical home. This is a new QPP reporting. It creates, as I said earlier, in the current rule, you don't have a choice. If you're in certain Medicare models, value-based purchasing models, or an ACO, you have to report an APM. You can't have, your toe in the MIPS piece and your toe in the APM. In the proposed rule, they are changing this, and this is something that has gotten some comments that folks actually like, and they create a hybrid MIPS APM. So now there are really 3 available programs as put forth in the proposed rule, which is the traditional APM model, the traditionally proposed MIPS model, and now the hybrid MIPS APM reporting model, which does not yet have an acronym, but I'm sure it will. So providers really need to make the effort to get ready on these. If you're ready, you will definitely have an advantage as this goes forward. So even though we are sitting on a proposed rule, that doesn't mean that the proposed rule is going to replace the final rule in everything that is proposed out there. I think anybody who's been in the industry for longer than 6 months knows that that is always the case. But always operate under the assumption that the rule that is final now may stay final. So we'll all be watching. They are promising that this final report will be out in December. However, last year I can say that this final rule that we're operating under now actually came out 2 weeks early, and it came out the middle to the end of October. It's definitely something that folks should be watching for to see what is in the final rule. If you have not read in detail any of the really good FAQs that are out there or the summaries, I strongly suggest that you do that. And I encourage folks who are interfacing with physician practices or accredited physicians to actually engage them, if you haven't already done so, to make sure that they know that this is not ICD-10. It is not going to get delayed for a year. It's not going to go away. So that is definitely something I encourage you to do. Check out the CMS website. It's absolutely phenomenal. There's great PowerPoints that you can download. There are, as I said, the algorithms, and there's also videos. And also look at hospital compare, physician compare, to see how physicians are practicing right now and how well they're doing. So what do you need to do? Familiarize yourself with requirements of the MIPS. Very important. Even if some things change, we still know that 80% of practitioners are going to fall under the MIPS requirements. They're out there. Trust me, they are not as complicated or as convoluted as the old measure set requirements that we're used to, that many of us are used to. These are measures very consistent with what CMS and Joint Commission have moved to on the inpatient side. They're a lot easier to navigate. Check now with your EHR vendor to make sure they can track the MIPS measures. There's always lessons learned as there's new programs that are out there. Some of the lessons that we all learned with the ECQM piece of this was that while an EHR vendor would say that, yes, we're capable of creating the required file, and we are capable of supporting it, what folks didn't always know till the last minute was that it was a certain version, and that was not the version that they're on. So that's definitely something to check with the EHR vendor. If you're in a situation where these are practices that are just credentialed and not employed, encourage them to do this, especially if you're asked, to give them some guidance. Decide how the practices are going to report these. Now is the time to do this, not in January, because really look at it, because you're going to want to get a feel for whatever tool you're using, as well as to see what the reporting capabilities they have to show how well folks are doing, or where they are having some challenges, and bring that to the CDI team and the coding team to work with the practitioners to ensure that the documentation is there to support the codes that are needed to support the measures, and track your progress. Look at this. Even if you don't have to report for more than 90 days, it's always prudent to start tracking as soon as something becomes available, even if you were using it for internal purposes only and not required to report it out. Familiarize yourself with requirements. Important, again, decide whether clinicians will report individually or as a group. Plan to report a minimum of 6 measures. Look at those measures, go in, run the algorithms, or if you are charged with doing education to, for physicians and other practitioners who are, or if you are a practitioner who is impacted, go in, look at them, play around with them. Know what, if you did report, or if these practitioners did report on PQRS, know how well you did, and realize that again, these are national peer benchmarks, not just your own performance on measures. Be prepared for an audit. We all know what's going on. We've seen the media. We know that audits are going on. So be prepared. Don't assume it's not going to happen. And obviously do your due diligence and keep accurate files. These are some resources that are out there. Again, I say, as I mentioned, CMS has a fabulous website dedicated just to MACRA. You can Google MACRA and you probably get 5,000 results within, Google's 0.7 seconds. But there's a lot of resources out there. Some, as in any case, some not as accurate as others. Always arm yourself with CMS requirements and use those as a guide when you use other resources. When you're preparing your coders, the AAPC website, which is the American Association of Professional Coders, has some very good information out there specific to coding in this new quality performance payment world. Thank you, and thank you very much. I hope you enjoyed this. I hope you found it informative, and we'll help you gear up to actually be ready. And Jackie, I'm going to turn this back over to you at this point.
Great. Thank you so much, Kathy, for that very informational webinar. At this time, we would like to open it up for questions, so please go ahead and submit your questions through the Q&A function. I see we already have a couple of questions coming in, but we do have about 10 minutes, so please continue to submit them. And Kathy, I will turn it back over to you to go ahead and read the questions that we have in and respond to them.
Okay.
If you can't see me, let me know, and I can read them for you.
No, I can see them. Okay. There's a question about group reporting, that if the group reports together, they must report on 15 quality measures, and that the writer's understanding is that is only applicable to the folks who use the web interface. That is not my understanding, Kim, and that is not what I have heard, but I will get the answer to that from one of my other subject matter experts, and we can get the answer back out to you. MIPS for groups under 110, do they need to report? And that is pretty much the same question as Kim's. And Rebecca, I will get you out the answer to that as well. And does MACRA also apply to freestanding inpatient psychiatric hospitals? It applies at this time, to the best of my knowledge, that it does apply to the physicians within those arenas, whether they are employed physicians or they are credentialed physicians. Question, why are incentives more likely if reporting through claims attestation? It's not the incentive. Well, when we talk about incentives, there's a couple of them out there to talk about reporting. Why we are questioning people about the EHRs is that you really need to make sure that there are the ability to have reports to know where your deficits are or to know where your strengths are. And as I mentioned, it isn't always the case, if you will, with the EHRs, and you may not have the best outcomes. It's not necessarily incentives. It's just the ability to get all of the information that you need. Are there templates, for example, like a MIPS for Dummies? Yes, quite honestly. CMS, as I mentioned, has a fabulous website. It is the best I've ever seen, and they have templates. You can export them. They have, and it's free, of course. And they have all the Q&A out there. So I recommend to everybody. And I've talked about MACRA and MIPS a lot. I always tell folks to go out to the CMS website. It's your best place to start. Even if you want to engage with a firm or a consulting firm or an EHR or some other consulting group, it always, as in anything else, it always makes sense to have at least a working knowledge, so what you're being told is actually on point. Is the up to 4% adjustment for 2019? Yes, that is due. No, it is not due January 2018. It is due March 31st of 2018. They do give you the grace period, and that's 2017 data due in March of 2018. We belong to an ACO, so we fall under APM. How do we check that all of our providers are included and that there are not others that need MIPS reporting? I would look and see now rather than later, and I think that's a great question, to make sure when the ACO was incorporated that all of the practitioners within the practice are included in that as well. So I would look at that, and then that's something I should probably add to my future deck. I think that's a great question, because you're right. If everybody was not included, and depending on how the ACO was structured, you may be in a position where you have folks reporting as APM and some reporting as MIPS. And I think that I also suggest very strongly that in the interim, in addition to doing the verification, that you look at the proposed language for the hybrid MACRA, the hybrid APM and MIPS model, just to see if that's something that's going to be included. What are HCCs? HCCs are higher, I can't even speak anymore. They are hierarchical care conditions, and what they really do is they follow a patient across the entire continuum of care, whether that be inpatient, outpatient, a minute clinic, a pharmacy, a community health fair. It's really geared towards population health and managing the entire population. Okay, we are a physician-owned surgical specialty facility within a small Medicare base and find that fit challenging. I can understand. As a result, we have not started with data collection or reporting. Have we missed the window? You have not missed the window. So remember, you do not have to report until March 31st of 2018. So you do, and you only have to report a quarter's worth of data. So that's not a large amount of data. So you can go back and retrospectively do it. I don't recommend you go back to January 1st, but since you only have to report 90 days, you may want to go back. I wouldn't report for the whole year. You may want to go back and look and see which quarters you performed the best in, to make sure you get the money that you are entitled to. What are the source related for the groups? The source is the CMS website. Okay, I think we're good, Jackie.
Okay, great. That's so great that we have so many wonderful questions coming in. This next slide illustrates our upcoming NAHQ webinars, so please don't forget to register for those. And I see several questions asking about a recording of today's webinar. So just a reminder, we will send out a recording of today's webinar, and that is complimentary access to all NAHQ members as well. Also, just a reminder, NAHQ Next, our annual conference, will make its return in September in Cincinnati, Ohio. So please don't forget to register for that. And I also want to just remind you that Kathy will actually be speaking at our annual conference as well, so make sure to check out her session there. And in conclusion, a special thank you to our sponsor, Nuance, and thanks for all of those who participated on today's webinar. Please take a few moments to complete the brief evaluation and enjoy the rest of your day. This concludes our program.